A 32-year-old morbidly obese male presented to our emergency department complaining of right knee pain after slipping and falling. On exam, his right knee was swollen, most notably over the anterior and lateral aspect of the knee, with overlying tenderness to palpation and a very limited active range of motion due to pain. The leg was neurovascularly intact. An X-ray was obtained and the radiology report was read as showing osteoarthritic changes of the knee without evidence of acute fracture or dislocation. Given the extent of the pain and edema, we looked at the images independently, and concern was raised for a tibial plateau fracture as well as a patellar dislocation. The location of the patella being quite high-riding further raised suspicion for this being a superior patellar dislocation. Superior patellar dislocations are uncommon, as more commonly the patella dislocates laterally. This distinction is important because the reduction technique is a little different. In the commonly encountered lateral patellar dislocation, while the hip is flexed, the patella is usually gently pushed medially while slowly extending the leg, resulting in reduction. In a superior dislocation, however, the patella is gently rocked from side to side while gently pushing it inferiorly. Another important thought here is that when you see a high-riding patella after trauma, suspicion should be raised for a patellar tendon injury. Obesity is a risk factor for this, and in our case, the patient was indeed obese. We decided to order a CT scan of the knee to verify the presence and extent of a potential tibial plateau fracture, which was indeed confirmed by CT. We could also see significant infrapatellar effusion as well as the high-riding patella. Initial attempts were made to try and reduce the patella, however, it would not reduce. We then performed bedside ultrasonography, which confirmed a total rupture of the patellar tendon, explaining why the reduction attempts have failed. Overall, this patient had a comminuted tibial plateau fracture and a total complex patellar tendon rupture. He was admitted to the hospital for intraoperative repair. The bottom line is, 1. Get into the habit of looking at X-ray images yourself, even if they are read as normal. With time, you will learn how to read those yourself. 2. When you see a high-riding patella, consider patellar tendon rupture, especially when you see a large effusion and if it doesn't reduce. 3. Bedside ultrasound is your friend here. It is a quick and easy tool to use that will help you rule in or rule out patellar tendon injury. And lastly, remember that the technique for reducing a superior dislocation is slightly different than the more commonly encountered lateral patellar dislocation. I'll see you next episode, inshallah.